Hello, I am Geronimo Farré, and in this video, Professor Wellens and myself want to discuss with you a case of narrow QRS tachycardia. This electrocardiogram was recorded in the emergency room from a 28-year-old male during an episode of acute palpitations lasting for more than 1 hour. The patient was very nervous and refers a history of brief recurrent palpitations for more than 15 years, developing in relation to physical exercise and frequently terminated by squatting. What do you think of the tachycardia documented at our emergency room? We offer you 5 possibilities: AV nodal reentry tachycardia, atrioventricular reentry tachycardia using an accessory pathway, atrial tachycardia, atrial flutter, or even the possibility of declaring that you can tell from this electrocardiogram. This was a regular narrow QRS tachycardia at a rate of 167 beats per minute, corresponding to a cycle length of 360 milliseconds. How to start the diagnostic analysis in this case? We will start discussing with you in this video a 3-step algorithm for patients with a narrow QRS tachycardia. The first step is the presence of second-degree atrioventricular block during tachycardia, either spontaneously or induced by either vagal maneuvers or drugs, such as adenosine or verapamil mainly, or diltiazem intravenously. In this case, we don't see second-degree atrioventricular block. It's true that still we don't have information regarding the effect of vagal maneuvers or drugs, but then we'll proceed to the second step, and then the question is to see if there is, in this case, QRS complex alternance during this tachycardia. In this 12-lead ECG, because of the superimposition of the QRS complexes in the precordial leads, it is difficult to appreciate the clear existence of QRS complex alternance in lead AV3. The presence of QRS alternance during a regular narrow QRS tachycardia suggests an atrioventricular reentry tachycardia as the underlying mechanism, an AVRT using a fast-conducting accessory pathway. The physicians in the emergency room perform a carotid sinus massage. You should notice several things in this case. First of all, that vagal stimulation terminated the tachycardia approximately here, and that also carotid sinus massage triggered a run of non-sustained polymorphic ventricular tachycardia, after which we see that the patient goes into sinus tachycardia without pre-excitation. The cycle length of this sinus tachycardia was 420 milliseconds, similar to the cycle length of the paroxysmal supraventricular tachycardia. Because of this, our physicians on duty did not realize that the patient had regained sinus rhythm, and they infused 2 boluses of intravenous adenosine. The patient was nervous, and sinus tachycardia reflects here a situation of increased sympathetic discharge. This case was discussed during an interactive voting ECG session, and the great majority of people in the audience, 63%, thought that this was an AV nodal reentry tachycardia. In fact, our cardiologist on duty also thought that this was an AV nodal reentry tachycardia. Note, however, that a significant number of people, as many as 21%, declare that they couldn't tell what was the type of supraventricular tachycardia in this case. Are you able to see P waves in this electrocardiogram? It is not easy, so we are going to see an enlarged view of this ECG. Here we show an enlarged view of several electrocardiographic leads during tachycardia, where you can appreciate P waves that are negative in lead AVL. You see them here. P waves that are of very low amplitude but negative in leads 2 and ABF. Here in an enlarged view of lead 2, we see better that after the QRS complex we have tiny negative bimodal P waves with an RP interval that was of 110 milliseconds, much shorter than the PR time that was 240 milliseconds. In lead V1, the P waves seem to be positive also after the QRS complex. This pattern is compatible with an atrioventricular reentry tachycardia using an accessory pathway, and because the P waves are negative in lead AVL, we anticipate a left free wall accessory pathway. As indicated before, in lead V3, we see clearly the presence of QRS alternance, and this is also suggestive for an atrioventricular reentry tachycardia using an accessory pathway. The patient underwent an electrophysiological study that demonstrated the existence of a left-sided concealed accessory pathway that was successfully ablated. The take-home message in this case is look for QRS alternance in regular narrow tachycardia. Thank you very much for your attention.